Good morning, everybody. Thank you so much for being here at Georgia Heart Grand Rounds. I need to share that there is no commercial support for today's program. Any financial relationships with the planners and speakers have been mitigated. If you have a question for the presenter, please wait until the Q&A time. If you are viewing online, you can post your questions in the Q&A section and we'll read it aloud. Also, the link to the evaluation will be posted in the chat section. It is a privilege to introduce Dr. Riaz Mahmood, our Chief Fellow for Research, Innovation, and Simulation. Dr. Mahmood brings a unique, multidimensional perspective to cardiology. His career began at the bedside as a nurse at Duke University Medical Center, where he was involved in the development and management of various phase 1 through 4 clinical trials, followed by a master's in biotechnology from Johns Hopkins. He received his medical degree from Campbell University's School of Osteopathic Medicine in Buies Creek, North Carolina. He completed his internal medicine residency here at Northeast Georgia Medical Center and also served as the PGY4 Chief Resident for Internal Medicine. After graduating from Cardiology Fellowship, he will join Sanford Health and the University of South Dakota. Dr. Mahmood's work focuses on the intersection of cost-effective healthcare delivery and clinical outcomes, driven by a career-long dedication to improving patients' quality of life. In his free time, he enjoys spending time with his wife and 3 daughters. Please join me in welcoming Dr. Mahmood.
Thank you. Good morning, everyone. Thank you for being here this early. So today I'm going to talk about beyond ischemia, the case for CT first strategy in chest pain. So for years, we've focused on functional or ischemia testing to find flow-limiting lesions. So today I'm going to make a case for shifting that to an anatomical strategy. So we'll review why CCTA, or coronary computed tomography angiography, should now be considered as first-line testing for majority of your patients presenting with chest pain. So unfortunately, I do not have any disclosures with any sponsors or anything that we'll discuss in the presentation today. All right, so my objectives that I'll cover today is evaluate the rationale for a CT first strategy in stable patients and those presenting to the ED or in the acute setting, and then apply guideline-directed use of CCTA to select appropriate patients for CCTA, and then identify CCTA findings, including plaque burden, high-risk features that can alter management strategies, and then compare the diagnostic yield and clinical outcomes of CCTA versus invasive coronary angiography versus functional testing in evaluation for coronary artery disease or patients presenting with chest pain. And then recognize future applications for CCTA, including PCI, planning, ECG-less imaging, and iodine myocardial perfusion mapping. So we'll start with a case. So let's say you have a 64-year-old female in the outpatient setting. You're seeing them in clinic. So they're presenting with substernal and exertional chest pain that improves with rest. ECG is unremarkable. And then they have a past medical history of hypertension, hyperlipidemia, class 1 obesity with a BMI of 32. So what's your next best step? So we know that heart disease is the #1 killer of patients or people in the United States. 1 in 5 total deaths are attributed to coronary artery disease. And so every 26 seconds, we know someone gets an ACS event, and every minute someone dies from heart disease. Okay, so certainly this patient's high risk, and we don't want to miss any of those things. So we want to send them for invasive, we want to skip the non-invasive testing and go directly to invasive coronary angiography. And that's generally what we would do for this patient. And then we would, traditionally have used the model of using Diamond Forrester classification. So if we classify this patient who's 64 years old, so if you look, it's highlighted in red for you in the box, but this patient has typical anginal symptoms. She's 64, she's a woman, so she has about 86 pretest probability that she has obstructive coronary artery disease. Now, certainly, you're sitting down with the patient, you're going over risk benefits, and so you discuss the risks. The risks for an invasive coronary angiography includes things like death, myocardial infarct, stroke, arrhythmias, coronary dissections, unplanned bypass, pericardial effusion, which can lead to cardiac tamponade, and then pericardiocentesis, acute kidney injury from contrast, and then vascular injury, which has lessened now that we've gone to a radial approach from a femoral approach, and then contrast reactions themselves. Now, these rates are really low, 1 to 2%, but I'll make a case that when you add these up, they aggregate over time. When you're talking about thousands and thousands of patients, 1 or 2% is a lot of patients. So this patient goes for cath, and here's the cath films. So here we're looking at the right coronary artery, and you can see that there's no obstruction. And now we'll look at the left side, and you can see the LAD is the one where the arrow is pointing, and then up at the very top was the left circumflex. And both of those, there's no lesion there. All right, so let's say this patient had gotten a nuclear study done prior. And so the cath films and the nuclear study are from the same patient. So here you can see that there is a defect in particularly a moderate-sized defect in the anterior and anterior lateral walls that looks reversible when you compare the resting and the stress images. And the degree of ischemia is pretty moderate, right? So, and then corresponds to traditionally the left anterior descending artery, right? But as we saw, there was nothing there. So what's going on? What happened? So when we look back now at the Diamond Forrester, we realize that that overestimates the degree of coronary artery disease that somebody truly has. So when these patients go for coronary angiography, which is the definitive procedure, it's not benign, so you are putting them at risk for complications. And so what really is the rate of obstructive coronary artery disease? So we have data from the New England Journal of Medicine article published by Patel and colleagues that showed us, what is the yield of elective coronary angiography for chest pain. So they looked at the ACC, American College of Cardiology, NCDR database, which is the National Cardiovascular Data Registry, from patients undergoing cardiac catheterization. So NCDR is the largest, most comprehensive outcome-based cardiovascular patient repository that we have in the US. And so if you look, you'll see that 60.3% of the patients out of the 2 million patients they looked at had across 663 sites that had gone cardiac catheterization at obstructive CAD. So then let's exclude some people. So excluding patients that had a prior MI, had undergone PCI in the past, CABG, underwent cardiac transplant or valve surgery. Now that number drops to 51.7, but then you further exclude them, they had an emergency indication. For example, they were having an ACS event, AMI, or were in cardiogenic shock. You're down to 36.2%. And then if you exclude owing to any other indication for diagnostic catheterization, so some other reason, you're really left with 37.6% of patients in the registry that truly had obstructive heart disease. So what I'm saying is that someone presenting with chest pain, the real obstructive coronary artery disease, and they have no known prior disease, is really 1 in 3, right? And that's really astounding when you think about it. And then some studies, like the discharge trial, showed us that the incidence of obstructive coronary artery disease is even lower, somewhere closer to 25%, so 1 in 4. So 3 out of 4 patients is getting a cath that don't need it. So what is the real pretest probability? So when we look at the guidelines from 2021 for ACC chest pain, we can see that we are going back to our patient, the 64-year-old female with typical chest pain, anginal symptoms, we can now reclassify and it's less than 16%. Big difference. So Diamond Forrester told us that she was 86%, and here now we have reclassification at 16%. So when we're looking at chest pain evaluation, we should consider the guideline approach here, which is a pyramidal approach for risk stratification. So most asymptomatic patients, they don't need any so they really shouldn't be, because they don't have chest pain, they don't really need any kind of testing. Except for, there's some rare subgroups. Then low-risk patients, you can get a calcium score for those patients. Intermediate-risk patients, you can do either anatomical or functional testing, and I'll make the case today for anatomical testing. And then high-risk patients or ACS could also, certainly for ACS, you want invasive coronary angiography, but high-risk patients, they can undergo either anatomical or functional testing or invasive coronary angiography. So how do we decide between these? Well, what should we focus on? Is it anatomical testing? Is it ischemia testing? And what do the guidelines say? So both of these have a class 1 recommendation. So when we talk about anatomical testing, we're talking about CCTA. So for intermediate high-risk patients with stable chest pain and no known coronary artery disease, CCTA is effective for diagnosis of CAD, for risk stratification, and for guiding decision treatments. And then for stress testing, class 1 recommendation with level of evidence at B. For intermediate high-risk patients with stable chest pain and no known CAD, stress imaging is effective for diagnosis of myocardial ischemia and for estimating risk of MACE. So balanced ischemia from nuclear testing or from functional testing relies on this idea of inducing a supply-demand mismatch. So that creates a physiological blind spot that completely misses some of the most severe disease like left main disease or severe multivessel disease. And the reason for that is generally how we assess myocardial perfusion is it's relative myocardial perfusion, so you're comparing one area to another. So the imaging agent distributes throughout the whole heart muscle, and you look at proportional to the blood flow. So if there's a reduction in blood flow, there's going to be less of that imaging tracer or imaging agent in that area. So the software then compares the uptake in one myocardial territory from another, and it gives you the comparison between a healthy segment and a disease segment. So in 2003, Lima and colleagues demonstrated that if patients presenting with critical left vessel disease, 3-vessel disease, let's say all 3 major epicardial vessels have something along the lines of 80% stenosis or greater, the entire myocardium is uniformly hyperperfused during the pharmacological or exercise stress testing. So then the imaging algorithm, the computer, sees a uniform uptake and interprets the scan as negative or completely normal. So this, unfortunately, creates an issue here because now you're completely missing triple vessel disease. And so here we can see 143 patients with angiographic data and then where they missed triple vessel disease. So the PROMISE trial really highlighted this discrepancy between comparing functional testing and strategies against anatomical CCTA. This trial included about 10,000 patients with new stable chest pain that were divided into either a CCTA arm, 4,996 patients, or a functional testing arm, 5,007 patients. There were across 193 clinical sites in Canada and the US. And so what this did is it recognized the functional tests were frequently generating false negatives in highest risk cohorts. So half of the heart attacks were happening in patients that the testing said did not have any critical blockages. So a stress test would have told the patient that they were just perfectly fine, but if we had looked at the plaque burden from CCTA, it would have recategorized them as a higher risk patient. And so the blind spot of stress testing was definitely a highlight from this trial. So here we can see, for example, if you look at the CCTA arm and the functional testing arm and 12-month outcomes, you'll see that across the board, the functional strategy had higher rates for all-cause death, for non-fatal MI, unstable anginal hospitalizations were actually lower in the functional strategy, but everything else looked higher. And the reason for that is we cannot treat what we cannot see, right? So then came the ischemia trial. So, enrolled 5,000 patients with stable with moderate or severe ischemia documented on a functional test, either echo, nuclear, MRI, EKG. And then 73% of these patients underwent a blinded CCTA run-in phase, and patients that had an unprotected left main were excluded from the trial. But they did include significant amount of diabetics, 42%, 47% had left LAD disease, left anterior descending, and 76% had multivessel CAD. Since we already know that left main benefits from survival benefits, that's why they had excluded these patients. So in the invasive strategy arm, they directed them straight to cath lab for optimal medical therapy plus an angiogram and revascularization via either stenting or bypass. And then the primary outcome they looked at was time to death, MI, hospitalizations for stable angina, for unstable angina, and heart failure or resuscitated cardiac arrest. So here is the results. So death for any cause. As you can see, there's no difference between the invasive arm or the conventional arm. So over a median follow-up of about 5 years, the adjusted hazard ratio was 1.05. So cross is pretty much null, essentially no difference. All right, so no difference was also seen when we compare different types of ischemia. So what if, these patients, you could make the argument, well, they didn't really truly have severe ischemia. So when we look at severe ischemia, we can see that the conservative arm should have worse survival for if they have severe ischemia, but that's not the case. As you can see in the most left-hand graph between severe ischemia, between the conventional arm in blue and the interventional arm or the invasive arm in red, you can see that there's no difference in all-cause mortality. So the data shows us that even when a stress test performed perfectly, when it accurately identifies moderate to severe ischemia, you still don't get any difference in outcomes. So the trial provided evidence that in stable ischemic heart disease, routinely deploying a stent for a flow-limiting stenosis did not prevent any changes to outcomes. So what really then predicts outcomes, right? So this is the same information in a different way. This was an analysis of the ischemia trial, a sub-study conducted by Reynolds and colleagues and published in Circulation in 2021 that looked at this sub-study. And here what they did is they leveraged that baseline CCTA data. Since the severity of ischemia on the functional test failed to risk stratify the mortality risk, they went back and analyzed the CCTA data to see if there was any anatomical severity of the disease, if that would predict it. So as you can see here, all of those cross 1. And so 1, when you have a risk ratio of 1, it basically means there's no difference between either lower or higher risk, so no difference at all in outcomes. So here, when we look at plaque burden, you can certainly see this tells you a different story. So they found that when they stratified outcomes by anatomical extent of the coronary artery disease, quantifying the plaque burden and the number of vessels involved, there was a clear dose-response relationship that emerged with all-cause mortality and subsequent myocardial infarction. So the physical burden of the atheroma, the structural disease actually within the wall, might be the driver for outcomes rather than just ischemia. So as you can see here, 3-vessel disease had higher risk than certainly 3-vessel or 2-vessel with 70% proximal LAD for all-cause mortality, for myocardial infarct, and for primary endpoint. All right, so then when we look at the SCART Heart trial published in the New England Journal of Medicine back in 2018, so this was a trial, multi-center randomized controlled trial of 4,100 patients with stable chest pain. The patients were randomized into 2 pathways, the standard care plus coronary CTA and standard care alone. So follow-up was over nearly 5 years. And there was a reduction in primary endpoint of death from coronary heart disease or non-fatal MIs. And this is significant. You can see the hazard ratio here of 0.59. That's a 31% relative risk reduction in cardiovascular events, purely derived from adding an anatomical test. So the question is how does a diagnostic test improve outcomes? So what happened is it's, again, going back to that idea of you can't treat what you can't see. So it's a behavioral change on part of the physicians and the patients. So the physicians were much more aggressive in ordering or further medical management, and the patients were much more compliant with taking medications and adhering to the medical plans. So there was a higher degree of prescriptions for aspirin and statins in the CT arm compared to the non-CT or standard of care. And then there was also a 4-fold increase in statin use, 12-fold increase in aspirin use. The greatest intensification was seen in patients under the age of 65 that were not previously on any optimal medical therapy. And then 64% relative risk reduction in coronary artery death, MI for diabetics managed with CCTA. So if we go to the revascularization guidelines, you can see ischemia is not an indication for revascularization, according to the 2021 ACC guidelines for coronary artery revasc in stable ischemic heart disease. So indications to improve symptoms. So those include refractory angina, anginal symptoms, anatomical indications to improve survival. So those included, for example, left main disease, and then CABG for multivessel disease with a low EF. And then should CCTA be the gatekeeper for going to the cath lab? So here was the discharge trial. So the discharge trial was published in the New England Journal of Medicine in 2022, included 3,667 patients randomized to 26 centers, and they either went CCTA or invasive coronary angiography. So we compared CT against ICA, and as the first diagnostic step for patients presenting with stable chest pain and an intermediate risk for coronary artery disease. And so we have here a Kaplan-Meier curve showing us primary composite outcome, which included cardiovascular death, MI, and CVA. And the cumulative incidence of the primary and composite outcome for MACE, you can see was low, 2.1% for CT and 3.0% in the ICA group. Hazard ratio was 0.7. The confidence interval did cross 1, goes from 0.46 to 1.07, and then your p-value is non-significant at 0.1. In the discharge trial, only 22% of CT patients required a invasive coronary angiography after getting the CT. So then there was a meta-analysis done by Machado and colleagues, published in Circulation Cardiovascular Imaging, that compared the analysis from 5 randomized controlled trial, total of 5,727 patients, and then they pooled all these together. And the kind of thing that I want to highlight is a remarkable 77% of the patients randomized to the CCTA arm that had undergone first diagnostic pathway did not end up requiring subsequent invasive coronary angiography. So a reduction of 80% of cath volume for elective coronary angiography. So that's a massive optimization of clinical resources. So, maybe we should consider that, so then your interventional staff, your cath lab staff are much more apt for performing procedures rather than doing elective coronary angiographies. So back to the guidelines. So if you noticed, there is a little bit of a difference in the verbiage and what they recommend for anatomical or ischemic testing. So if you looked at the anatomical testing, it's more for diagnostic purposes. So for CCTA, for diagnosis of CAD, for risk stratification, and for guiding treatment decisions. And then for SPECT or functional testing, it's much more prognostic for diagnosis of myocardial ischemia, and for estimating risk of MACE. So shifting a little bit to the acute setting, so acute chest pain in the ED, we'll take the same patient, 64 years old, presenting with substernal exertional chest pain that improves with rest. ECG is unremarkable. Your troponins, gray zone, 82 initially, repeat is 110. And then past medical history of hypertension, hyperlipidemia, class 1 obesity. So what's the next step? So CCTA first strategy, Atrium Health, Sanger Heart and Vascular Institute, between October 2022 and June of 2023, they looked at 786 patients who had no known prior coronary artery disease and underwent elective invasive coronary angiography for the evaluation of suspected angina. So what they found was researchers compared subsequent revascularization between both arms, the CCTA strategy first and a combination of other modalities. The CT first strategy was associated with subsequent revascularization in 62% of patients compared to 34% for the combination of other modalities. So here was a meta-analysis performed by Barbosa and colleagues published in Radiology Cardiothoracic Imaging from 2023. And it evaluated comparative effectiveness of CCTA against the standard of care for acute chest pain acute chest pain triage. So when comparing CCTA arm to the standard of care arm, the risk ratio for all-cause mortality was 0.83, with the confidence interval crossing 1, as you can see. And this is group 1, so which is low to intermediate risk for ACS. And then if you'll look at group 2 here, this is high risk for ACS, similar findings here. So you have a hazard ratio of 1.06 with a confidence interval of 0.56 to 2. So no difference there in mortality. So when we look at length of stay for acute chest pain, so same thing, we're looking at group 1, low to intermediate risk. You see a slight benefit for the CCTA at 0.083 and 0.74 to 0.9 for the confidence interval. And then when we look at the higher risk group, the benefit isn't as clear. Your ratio is 0.97 here, confidence interval does cross 1. And then when we talk about CCTA reducing costs, so costs for the hospitalization were lower in the CCTA group with a ratio of 0.79 and confidence interval of 0.7 to 0.9. And no difference, again, here in the cost reduction here for these patients in the high-risk group as well, a little bit lower. So benefits of CTA. So patients under the age of 65, CCTA is preferred, according to the guidelines from 2021. And then higher likelihood of non-obstructive disease, benefits of early preventive therapy, intensification, superior sensitivity, so highly sensitive for detecting obstructive coronary artery disease compared to stress testing. And a really good negative predictive value. So a negative CCTA has an exceptional low event rate, so less than 1% at 3 years. And then plaque characterization, so visualizing high-risk features such as positive remodeling, low attenuation plaque, and functional testing. And that functional testing often misses. So, traditionally we've thought of coronary artery disease progression as sort of a linear model. So classically, we think plaque starts out, grows, encroaches on the lumen, and then as it goes from 40 to 70, 80%, and 90%, and at some point when it gets high enough, you have plaque rupture as fat deposition continues to build, leading to high-grade stenosis. But it's not that simple. There's a lot more complicated interactions there, inflammatory changes. And then if you look back, most of it is due to your vulnerable plaque that ruptures, causes thrombosis, doesn't really require a 90% stenosis. You could do that at 70%. And so the question then becomes, how vulnerable is the plaque or how vulnerable is the plaque to rupture? So when we look at vulnerable plaque, CCTA can help us with that. It identifies these 4 characteristics: spotty calcification, positive remodeling, low attenuation plaque, and napkin ring sign. So when we talk about spotty calcification, so you have these micro calcifications that are highly dangerous because they're small, scattered calcium deposition throughout the vessel wall. So what happens is as the vessel expands and contracts, it's sort of like a little rock rubbing on the vessel wall, creating mechanical shear stress that can cause it to rupture. When we talk about positive remodeling, the atheroma begins to accumulate lipid and inflammatory cells within the intima of the vessel wall, and that then starts to protrude outward as it grows. And so it actually does not encroach on the lumen. It actually, sorry, my mic fell. So it actually does not obstruct the lumen, but it rather grows outward from the vessel lumen. When we talk about low attenuation plaque, we're defining plaque less than 30 Hounsfield units. So when we say a large volume of low attenuation plaque, we're looking directly at massive lipid-rich necrotic core. And then the napkin ring sign. So when you have a central area of dark, low attenuation necrotic core surrounded by a distinct ring that's hyperattenuating, and that brighter rim represents that thin fibrous capsule or cap, which is often complicated by intraplaque hemorrhage or neovascularization from the vasovasorum. So basically, your body is trying to contain that volatile lipid-rich core. So then there was this trial done, the PREVENT trial, published in Lancet in May of 2024 by Park and colleagues, multi-center, open-label, randomized trial done at 15 research hospitals across South Korea, Japan, Taiwan, and New Zealand. And it asked the question of, what if we have vulnerable plaque and before it ruptures, what if we stent that? So coronary stenosis in this trial was greater than 50% with a negative FFR, and meeting at least two of the following criteria: MLA less than 4, plaque burden greater than 70%, TCFA by OCT or by IVUS, and then lipid-rich plaque by their calculation. So the investigators hypothesized that if you have acute myocardial infarctions that are primarily caused by rupture of plaque, then mechanically scaffolding or putting a stent there is going to prevent that. So they enrolled patients who, like we talked about the criteria, and then the lesions had to meet those strict criteria. And so their primary endpoint was target vessel failure at 2 years. And so they had 800 patients in each arm. And so then the primary composite was this target vessel over 2 years, and what they found was the preventative PCI arm demonstrated a profound reduction in this primary outcome compared to the medical therapy alone. So the hazard risk ratio here is 0.54. That's a 46% relative risk reduction achieved by prophylactic stenting of vulnerable plaque. And then when you look at the Kaplan-Meier curve here, presented from the trial data, the divergence is noted even at 2 years. You're looking at 3.4 versus 0.4. And then even if you follow it up out to 7 years, you'll also continue to see the difference at 9.4 and 6.5. So then there was a randomized meta-analysis looking at these randomized control trials. So 3 studies, including the one we just mentioned, PREVENT from 2024. The meta-analysis confirmed a highly consistent, statistically significant reduction in MACE events when high-risk plaque morphology is aggressively managed with preventative structural interventions. So the data suggests that maybe we should intervene on anatomical presence of high-risk plaque features rather than waiting for rupture. And then additionally, SKY recommendations for use of CCTA for PCI planning. So there is this expert opinion on coronary computed tomography angiography to guide percutaneous coronary intervention, expert opinion from SKY roundtable. So the key points here are listed, but essentially CCTA PCI procedural should involve direct visualization of the CCTA to guide and pre-procedural planning, and then CCTA assessment for the pre-procedural planning, and we'll touch on some of these, and then if available, utilization of FFR for the data, and then interventional cardiologists should be familiar themselves with basic terminology and concepts of CCTA-guided PCI. All right, so SCI recommendations for use of CCTA for PCI planning. So here, the CCTA data with FFR can give you information about the vessel course, tortuosity, help you select which would be the best engagement catheter, and delta and virtual FFR pullback tells you where the most stenosis is for that particular lesion. Can show you disease patterns. Is this a diffuse coronary artery disease? Is this focal? And then virtual PCI can show you what a stent would look like where when deploying from healthy to healthy tissue and what size you would need. So here is another sort of image here showing us what that would look like. So you can see here where the arrow is. I don't know if you guys can see my arrow. Yep. So here you have soft plaque. In this darker spot right there. And then, this white, bright, that's your calcification that you can easily see. But you can utilize that information then for the pre-procedural planning for PCI. So for example, it can tell you the morphology or characteristics of the plaque. Is this calcified? Is this soft? What the length is, and then the diameter of the vessel, proximal, distally. And then the optimal angle. So you want that angle when you're moving the C-arm, so where you get the orthogonal 0 foreshortening. And then the stent length as well. So future of CCTA. So ECG-less CCTA with free breathing. So new technologies coming out that they'll look at, for example, triple rule out from the ED. So someone coming in with chest pain gets one scan done one time. That rules out PE, rules out aortic dissection and pulmonary emboli. And then you can also see better, as the algorithms and technology improves, improvement in plaque characteristics. And so there's also this concept of iodine myocardial perfusion mapping that's coming across. So you can see areas that are hypoperfused better than we would. So then you add this iodine mapping over and you can see this blue area highlighted that shows you that's a hypoperfused myocardium. As technology improves, they'll also be able to see better for visualization of calcification. So currently one of the bigger issues is blooming artifact with calcified plaque. So that'll improve with time. Other advancements, so anybody that we traditionally would have excluded from getting a CCTA or was not the optimal candidate can now be considered. So renal impairment patients, so we already do this, but contrast can, with very little contrast in getting a CCTA done. So only 25 mLs, generally we use about 100. And then high-risk BMI patients, reducing the noise so you can get a good visualization of their coronaries. AFib, so no motion, low dose. Variable heart rate, so they have no motion and low dose. And then mixed plaque, so you can reduce the noise, you can get better signal-to-noise ratios there. And then stent follow-up, so low noise, high signal-to-noise ratio, so you can better clearly see stent anatomy and visualization within the stent for in-stent restenosis. And then ECG-less cardiac acute chest pain like we discussed earlier. So that concludes my presentation. So summary, so consider CCTA first for elective patients presenting with chest pain. We looked at the 2021 guidelines for chest pain for intermediate to high-risk lesions, class 1 recommendation for CCTA diagnosing coronary artery disease, risk stratification, and guiding treatment decisions. Low diagnostic yield for invasive coronary angiography. It justifies a CT first approach. A little over a third of the patients have elective catheterization show obstructive disease. And then CCTA should be the gatekeeper to the cath lab and utilization of PCI planning, so better sensitivity, specificity compared to functional testing, and then lower complications and costs compared to elective coronary angiography. And then anatomy trumps ischemia for predicting outcomes and guiding therapy, and emerging paradigm shift towards treating vulnerable anatomy. And thank you for everyone for attending, and thank you to my mentors, Dr. Egelam, Dr. Saeed, Dr. Parastatitis, and then these are my references.
Thank you so much, Dr. Mahmood. If anybody has any questions, please raise your hand. I'll bring the microphone right to you. If we have anybody watching online, please enter your questions into the Q&A and we'll read it aloud.
Thank you, Dr. Mahmood. I just have a question. In the Barbosa trial, the one comparing the CCTA and standard of care for acute chest pain, what was the standard of care specifically?
So it was whatever the sites deemed appropriate at that time. So whether it was,
cath or,
I'm sorry?
whether it was straight to cath or?
No, so it's whatever they deemed appropriate, meaning functional stress testing or cath, essentially. And then medications and everything, remember, these are not ACS patients. These are just patients with chest pain.
Right.
So again, they shouldn't be on heparin. They shouldn't be on any of those other medicines.
Okay. And my second question is there any, probably not, but is there any publications in terms of doing CCTA for patients, for high-risk patients, for instance, like early family history, smoking, vasculopathy? Is there any study like that for doing like a routine CCTA for them?
No, unfortunately, most of those higher risk patients get excluded from the trials simply because those patients have higher rates of outcomes. As we all know that, if you're a smoker and, you're, like 40, 50 pack year history of smoking is going to put you at a much higher risk profile compared to somebody that doesn't smoke. And then getting a CCTA, is it really that helpful in that case, right? I think early on, if there's stable chest pain in your clinic, it makes more sense. But if they're presenting to the ED, you just have to kind of put it all together. I still would try a CCTA first if we can. But if you have a higher suspicion that they have plaque rupture, then certainly getting an elective coronary angiography is a better choice.
Thank you.
Thank you, Dr. Mahmood. Great presentation. I know that the guidelines are pretty clear about patients who have no known coronary disease. We go for intermediate risk, we go for CCTA. But what about the patients who have, history of mild CAD? Very frequently, we get patients in the emergency with history of, CAD. They did an invasive angio or had a CT before, and they have minimal CAD, like less than 25%. And they come again a year or two later with chest pain again. What's your threshold to repeating a CCTA versus directing them somewhere else, like a provocative test or an invasive angiogram?
So I think that really depends on your threshold. I also don't think that we should keep doing the same test over and over because it's not going to give us different diagnostic information. So we have to vary the test. So what I would sort of look at is their risk profile. Did they have mild disease? Were they closer to moderate? And maybe now they're more obstructive disease. So they were in the moderate category last time. FFR was maybe negative or borderline. I would consider sending them for a cath. But if somebody, it was like sort of minimal to mild and they're representing with chest pain, I think it's appropriate to do CCTA in that category.
Any other questions? Do we have anything online? Dr. Egelam?
Yeah, so great presentation. I think hopefully for the fellows in the room, this was really a great overview of the last, 5, 10, 15 years of data around CCT and how it should apply it. And I like that you focused on the guidelines because these will come back in real practice. One of the things that's always come up, and I think this has affected the wide adoption of CCTA, is, of course, we have the clinical data, but of course, insurance or payers are oftentimes reticent to pay for CCTA. But I think there's clear evidence that for patients that obtain CCT in a correct setting, you actually reduce downstream utilization of cardiac cath, et cetera, et cetera. And that's always been one of the concerns where, if we have a CCTA, we're going to have more cardiac cath and more procedures and actually increased costs. Could you speak to why we still haven't seen increase in adoption despite clear evidence to the contrary?
So that's tough to answer, simply because one, as we know, insurance always lags behind evidence. So it takes a couple of years before insurance really catches up and starts doing, in reality, what the guidelines recommend. And then we know that CCTA actually reduces, based on the trials, meta-analyses, the number of patients that go for elective coronary angiographies. So, and then the cost for a CCTA is much lower compared to an elective coronary angiography. And the resource utilization for cath lab is doing elective coronary angiographies. They're not doing stents, right? So that's not the best and optimal use of the cath lab staff and the interventionalist. So I think CTA is better, but it's tough to say why we don't adopt it. I think part of it is clinical inertia. We're just used to doing things a certain way, and then we just continue doing them. But that's kind of why, I make this case for, should we change our practice? Should we, stent patients with vulnerable plaque before plaque rupture?
And we do have a question online when you're ready.
Excellent. The other thing I'll ask you to comment on, Riaz, could you let us know, just as a whole, because one of the other conversations that comes up is exposure to radiation. Could you let us know how low radiation exposure is for CCTA?
So I'll be honest, there's a difference in the literature and what we do here at NGHS. Our rates for doses for radiation are higher. But in the literature, if you do it truly the correct way, it's very, very minimal. It's not much higher than, a couple of X-rays, for example. The problem is our radiation doses are higher simply as how you order the test, how it's gated, how it's triggered. So, don't want to spend too much time, but for a brief brief information session. So when we do the ECG triggering, we can do it the whole cardiac cycle. So during systole and diastole, but if you just need coronary information, you can get away with just triggering in diastole in a short portion of time. So you can see that during the whole heartbeat, you don't need radiation. You just give radiation in that one spot when you need it. So that's like maybe 1 second or so. When we do retrospective studies, we're trying to gather more information. So you're getting more information about how the valves are functioning, how the heart's contracting, all of these. So when you scan during systole and diastole, you give more radiation. Now, you can certainly dose optimize. So where you reduce when you're really looking for something, you increase the dose of radiation. Otherwise, when you're just sort of background scanning, you reduce the amount of radiation you're giving. We unfortunately are not doing the best practices for that. I think we're getting there. I think there are some scans where our radiation is very minimal, but there are certainly opportunities there.
Excellent. Yes. And we do have a question in from Dr. Jacob. He's asking, for low to intermediate risk patients, how can we better educate referring physicians to order a CCTA first rather than a traditional functional stress test?
I mean, that's tough because, again, it goes back to, we're all here as cardiology discussing this, but I know CCTAs are open to family medicine, to internal medicine, so anybody can order it. So we're seeing patients, I wouldn't say they're inappropriate, but it's probably not the best test in a 90-year-old, right? Because we know they're going to have a high plaque burden. And so what am I going to really tell you? Like they have a whole bunch of calcium, right? So I think that goes to educational activities and better educating everyone on what is the appropriate use of the test. So the test ideally should be for patients under the age of 65. Certainly we can do it over. It's not a hard cutoff. But ideally we're looking for patients that have less obstructive disease with CCTA to rule out. So if patients don't have obstructive disease in that intermediate risk category, then you can be confident that the event rate is low enough, it's less than 1% in 3 years. So for the next 3 years, they're okay.
We have a question back here.
Good morning. Thank you for your presentation. So for our younger patients, how would you consider doing CCTA versus like functional treadmill testing? How would you decide between the two?
So again, it's what we're looking for, right? So if somebody has no known coronary artery disease, I make the case for a CCTA first approach in all of those patients, right? Because what really prognostic value are you really looking for? If they have other reasons, if you need to know, how long they can exercise, if they have obesity, if you think that the chest pain is related to exercise intolerance or something else, then you can consider that. But the best test that's going to give you anatomical evidence is going to be your CCTA. And so you'll know, how much plaque they have, if it's obstructive, if it's not. And so I think for those patients, for vast majority, I would pick CCTA. I would pick it if I'm also looking for other information. So for example, if they have aortic stenosis or something else that they would benefit from, exercise treadmill, that sort of thing.
Okay, thank you.
Okay, I don't see any more hands up.
I was going to ask another question. So final question. So, I think the CCTA data shows us that we really need to shift our paradigm about how we think of coronary disease. So rather than strictly, because a lot of emphasis has been on looking for obstructive disease, but if anything, it's pretty clear, particularly in patients with stable ischemic heart disease, that 80 to 90% stenosis is not necessarily going to kill you, if you will. However, we know, if we're using CCTA, we can clearly identify plaque that's high risk of rupturing. And as that PREVENT study showed, by proactively stenting and medical therapy, you can actually prevent MIs and impact cardiovascular outcomes. How do we get the field to start shifting in that direction? Because again, we're still predominantly focused on looking for obstructive coronary disease rather than vulnerable plaque and active.
I think that's a tough question and I'll be honest with you, it's tough to get people to change their practice model. Part of that is I think the first thing we have to do is we have to get rid of doing so many elective coronary angiographies, right? And then after that, you have now time to quote unquote start prophylactic stenting, right? I think, I'm a firm proponent of preventative care. And so part of preventing is we don't want the first time that you're seeing a healthcare provider or anything like that is when you're having a ruptured MI, right? So if we can get CCTAs on patients early when they have a little bit of chest pain, we can better risk stratify them, even in the acute setting, even in the ED. And with better risk stratification, then you can utilize that information to make the case that, hey, when we do stent these patients that maybe aren't at 70 to 90% stenosis or close to 100% stenosis that have vulnerable plaque features, that you do get better results. I think more data is needed to convince. I mean, that was one small study. I think, certainly every study has drawbacks. And so I think we need a larger randomized controlled trial from the US or Europe to show the same level of evidence that they found in that Asian study.
Don't forget it in the guidelines.
Yeah.
I see Glenn in the back. What are your thoughts on this topic, Glenn?
Side chatter back here. So I look at CCTA as a diagnostic cath, basically, right? So, for us in the cath lab, definitely increases our proportion of treatable patients rather than just and I will use the word clean cath, but as we all know, a clean cath doesn't mean there's no coronary disease, just means there's no critical obstructive disease. So it's probably a term that's not well suited for primary prevention of events. It gives the wrong impression. But I think there are multiple benefits of CCTA. It's cheaper than PET, stress testing. It's got less radiation. It is available 24/7. It doesn't require a physician present to supervise. It will decrease length of stay. It increases throughput from the hospital, and it can be ordered by the emergency room, the hospitalist, the family medicine for appropriate patients that doesn't even necessarily need a cardiology consult and will need a cardiology follow-up afterwards. So I think there's innumerable benefits from patient care perspective, financial perspective, throughput perspective, accuracy perspective, secondary prevention perspective. I think it's the test of choice. It's a cath without the risk, basically.
Thank you. We did have one more online. We'll take this as our last question, and this is from Dr. Said. It says, can you comment on leveraging information from prior chest CT, PET CT, cardiac cath in your choice of selecting non-invasive cardiac testing for stable chest pain? Our radiation dose is lower than national average and mostly less than, I'm sorry, I'm not sure what this means, 1 MSV. That is when preparation of the patient is a key to decrease the radiation exposure with optimal HR control. No, it's a long question.
So I'll answer the first portion of the question, which was looking back at retrospective information. So I think all of us do that to some extent. So especially when we see a patient for the first time, they're coming in for, a chest pain consult to cardiology clinic. We'll go back and look at their prior CT and see, because you can see coronaries on a prior CT for chest or, sometimes even abdominal pelvis, they'll go high enough that you can catch the coronaries. So if you look at the coronaries and you see they're heavily calcified, you already have an idea or suspicion that this is somebody with moderate to severe coronary artery disease with significant plaque built up. Whereas if you look at somebody else, you may not see much. Now, again, that doesn't mean, because again, the study isn't optimal for assessment of coronaries, because again, they weren't given nitroglycerin during that study. They also, were not truly able to see soft plaque as well. So I think there's some caveats to it, but I think, when you do see something there, it's certainly going to be helpful. The second part, I agree with Dr. Saeed. Yeah, our dose is lower for when studies are done properly. It is, lower than the national average. But at the same time, we do have some opportunities where patients, for example, have a PVC. And so when you have a PVC and you're doing a retrospective study, remember we talked about that one heart cycle? Well, guess what? You had a PVC. So now you got to go with the next heart cycles. And then you scanned for 2 cycles, right? Someone who has a very fast heart rate, then you get these blurry images, and now you got to scan for longer, right? So all of these things, I think we just have to work towards getting an optimal workflow for those things to optimize our dosing.